Thanks so much for joining us for the webinar today. We have a great presentation planned for you. We're going to be discussing MTHFR, COMT, understanding the connections of autism and ADHD, and how to treat the genetic variants. We have Dr. Jared Skowron, Dr. Valerie Ferdinand, and Ed Fitzgerald from Mtfhr. Without further ado, I'm going to go ahead and introduce Dr. Valerie Ferdinand. She has an integrative practice in Portland, Oregon. She also has her doctorate in naturopathy from NCNM in Portland, and she's also our lead clinical consultant at Kashi Health. She's here to support doctors in their use of genetic testing in their practice as well. So here is Dr. Valerie Ferdinand.
Thank you, Brian. So thank you all for joining us today. I'm very excited to be able to present this information on MTHFR and COMT and how they pertain to autism and ADHD patients. It's a very interesting topic, and I know we have a lot of interest and some wonderful experts to help inform you on this. So without further ado, let's get started. So today we're going to be going over the impact of the MTHFR SNPs on developmental disorders such as autism and ADHD. We're going to talk about the higher occurrence of MTHFR polymorphisms in symptomatic patients. We'll understand the mechanism of action of how MTHFR affects the pathogenesis of autism and ADHD and how these two genes interact to affect these patients. Dr. Skowron will be reviewing clinical cases that highlight how these SNPs can directly be supported, and will address questions you have for patient care. Now, because this information is intended for medical practitioners, we just want to make it clear that all information made in the context of this presentation are intended to be carried out through the proper guidance of a physician or other healthcare provider. It is highly recommended that members of the general public do not enact these changes without appropriate guidance. However, if you choose to, you enact these recommendations with your own responsibility and are encouraged to obtain medical assistance for appropriate treatment. So just a little bit of background about some of the companies that are involved in today's webinar. Here at Kashi Labs, we are focused on supporting our practitioners through clinically relevant genetic testing. Kashi Clinical Labs was founded in 2006 to address the unmet needs for accessible HLA testing in the transplant community, and we currently serve providers across the United States and internationally. We are accredited through CLIA, ASHI, and CAP, and we every day are working to provide the most scientifically rigorous testing available to our clinicians. MethylPro, a division of metabolic maintenance, is a professional strength L-methylfolate supplement. Almost half of all people have genetic variations that reduce their ability to convert folic acid to L-methylfolate, the activated form of folate. MethylPro promotes healthy mood, cardio, and nerve function and supports the production of the neurotransmitters serotonin, melatonin, dopamine, epinephrine, and norepinephrine. And MethylPro makes variable dosing options of L-methylfolate available direct to consumers at a big savings compared to competitive brands. Spectrum Awakenings is a supplement company focused on natural supplements to support children's healthy and normal development. All formulas are created by naturopathic pediatric expert, and they're happy to offer free samples for all families. Their products support healthy and normal language, behavior, and sleep in their patients. And with that, I'd like to hand it over to Dr. Jared Skowron. He has a private practice in Connecticut, is an internationally recognized autism expert, and a top Amazon bookseller for natural treatments in pediatrics and remedies for your children. He is the founder of Spectrum Awakenings, and we are very pleased to have him with us today. Dr. Skowron, I give it to you.
Thanks, Dr. Ferdinand. It's great to be here, and just a quick intro of why I'm helping out on this webinar. I've been in private practice for 12 years, focusing exclusively on pediatrics, and especially those kids with developmental delays and behavioral issues, whether that be a diagnosis of ADHD or autism or PDD or sensory processing disorders, etc. All of these developmental delays and learning and behavior issues really focus around the nervous system and neurological function. And, you know, if I rewind my practice 5-10 years before MTHFR testing and treatment was really popular, you know, I had a lot of struggles with some kids who weren't responding to treatment. Now that MTHFR testing and treatment is extremely popular and should be involved with any case in neuropsychiatric issues, we've had so much better response in a larger percentage of our kids. So I want to walk you guys through my practice and how I help these kids so that hopefully you guys can help kids out there as well. The first thing I talk about when we discuss anything is the order of disease. Now, everybody walks in with symptoms. Say, I've got problems with attention, or problems with distractions, or problems learning, or my language, or I'm stimming, etc. All of those symptoms come from our physiology. There's something inside our bodies that's creating that, and it's our job as physicians and health professionals to discover that physiology, because when we understand why this is occurring, we can choose the better treatment. Now, those physiological changes don't just happen. They occur because the body makes them happen because of some level of homeostasis or some level of inflammation. And all that inflammation and homeostasis eventually has some type of etiology. Now, maybe that's an etiological stressor like our nutrition or some type of toxicity. But in a lot of cases, it happens to be our genetics. So that's why genetic testing on anyone with a developmental issue or neuropsychiatric issues needs to occur. So I'm going to be talking about how MTHFR and COMT genetic abnormalities and mutations are part of this process, where that's part of the multifactorial etiology that's creating some type of homeostatic imbalance, that's creating the physiology, that's creating the symptoms, that's walking through your door. And of course, people want help with their symptoms. So let's move on to the next slide. This is a quick little line graph on how different diseases occur. Now this is really a line graph on how acute illnesses occur. Obviously, when we're dealing with developmental delays and ADHD and such, we're dealing with chronic disease. Now, most of the time, disease starts with some type of incubation, especially if we're looking at infectious disease, and then the aggravation occurs. And aggravation is inflammation, and that eventually, with acute illness, ends up in some type of destruction, hopefully destruction in the pathogen and not destruction in the patient. And then after that is some type of abatement and cleanup. When you've got a cold, after the cold, you've got to get rid of all your white blood cells and your mucus, whether it's your nose or your sinuses or your lungs, etc. And then reconstruction of the body occurs. So this is kind of a line graph of how acute disease happens. But in chronic illness like ADHD and developmental delay like we're seeing, there's never any end to it. It's just this continuing loop of inflammation that hasn't stopped, along with attempts at reconstruction. So we're constantly being inflamed and reconstructing, and being inflamed and destroying and reconstructing, destroying and reconstructing. And things never stop, and that's where we need to intervene. So let's move on to the next slide. So when we talk about all these different diagnoses, they're all subjective diagnoses. Nobody has anything really objective besides some surveys that tell us what's different from one to the other. Okay, is somebody ADHD, or do they have autism or pervasive developmental disorder? And it really just depends on the level of extremeness of their learning issue. And so when we have mild learning issues and mild behavioral issues, we diagnose them as ADHD. If they're moderate, they're pervasive developmental disorder. If they're extreme, we call them autism. But there's a lot of fine overlay between them all. So in my practice, we really group them as one. We group them as neurological imbalance and neurological dysfunction that we need to work on and treat. So let's move on to the next slide. The physiology behind it all, first off, starts in our genetics. As we mentioned, MTHFR and COMT are our primary genes, and Dr. Ferdinand's going to go over this again after I do. These are the primary genes that are controlling our neurotransmitter levels. Now, we also have a little bit of function with MAO, monoamine oxidase, but the ones we're going to focus on are MTHFR and COMT. So if you've got good genetics, that's a good start. If you've got bad genetics, that's a bad start, and we need to treat accordingly. On top of that, we've got our nutrition. So we could have the best DNA in the world, but if you're not getting good food, healthy protein, and healthy vitamins, the brain's still not going to work. Okay? And there's a lot of great research on people or animals that are deprived of tryptophan, and if you're deprived of tryptophan, you're deprived of serotonin. People and animals get very aggressive without enough serotonin. So again, you can have great MTHFR, but if you're not eating protein, you're going to become really aggressive. And then on top of that, we've got our epigenetics. And epigenetics, is a really popular term now, but epigenetics basically means the behavior and the lifestyle and the parenting for kids. So again, regardless of the genetics and the nutrition, if you've got bad parenting, if you've got a child who sits in front of the TV all day, they're going to be hyperactive. If you expose your child to some type of emotional trauma, whether that be divorce or what have you, there's going to be some behavioral issues. So not only do we have the genetics and the nutrition, but there's also the development and the nurturing of the child along the way. Next slide. Great. So let's start with a case study. This is NB. He's a 5-year-old boy. He was diagnosed with autism. As with many kids with autism, they were withdrawn and unsocial and didn't have many friends. This type of social awkwardness really occurs as a response to anxiety. If I'm feeling anxious, I don't want to interact with others. So he was anxious about kindergarten. He was anxious about interacting with other kids. He liked to interact with adults because he was used to interacting with his parents. So, whatever we're used to, we're calm with. Next slide. So we, sorry to jump that on you, Dr. Ferdinand. We do our testing as we do with all kids. So our next slide shows our initial testing. Now, initially, we're going to look at the neurotransmitters. So we look at 5-HIAA, which is up at the top. That's our metabolite of serotonin. It's a nice urinary marker of serotonin that we can get. We also test our catecholamines, epinephrine, norepinephrine, dopamine. So you can see the 5-HIAA is a 3.2. I like to see this around a 6 or an 8. So while it's not strictly abnormal on the labs technically can't be abnormal on the low end because the labs go from 0 to 12. You can't have less than 0. So again, I like 6 to 8 on my 5-HIAA and urinary markers. So in my opinion, his serotonin's low. If you look at the epinephrine, norepinephrine, and dopamine, the writing below that says that the level was so low that the machine couldn't find any. So I'm sure he has some level of catecholamines, but it's definitely on the lower end. So the first question is why? Why does he have a low level of all of these neurotransmitters? So we'll move on to the next slide and continue our investigation. First, I wanted to see if it was his nutrition. Anybody who's not eating enough protein will have low levels of neurotransmitters. So at the top, you can see his tyrosine level. Tyrosine, of course, feeds our catecholamines. That level's good. At the bottom, we see his phenylalanine, which feeds the catecholamines as well. And then we see his tryptophan, which feeds serotonin. Those levels of amino acids seem to be good. So it's not a protein deficiency for this child that's causing these low neurotransmitter levels. So we'll move to the next slide. And we get our MTHFR test. Okay, now MTHFR, and again, Dr. Ferdinand will go into the details of this, is the gene that is the primary producer of the majority of our brain chemicals, such as serotonin and catecholamines. So this child is heterozygous for the 677 mutation for MTHFR. For some people, that's only going to produce a mild level of dysfunction in neurotransmitters. For him, it produced a lot. And I'll tell you, in my office, people can have the same MTHFR mutation and have such a wide and varied clinical presentation. So what we really need to do is test everything, but take every individual as an individual. So let's move on to the next slide. And again, this is just a little summary. We tested his catecholamines. Those were all, his neurotransmitters. Those were all low. The amino acids were good, but the genetics were really the red flag for us as the etiology of why this child was having the issues. So that's where we focused our treatment. And move on to the next slide. And again, the next slide is just a little of the biochemistry, if you're unfamiliar, of how amino acids become neurotransmitters. So this graph here, and thanks to Metametrics for this graph, phenylalanine and tyrosine on the top left convert to dopamine, norepinephrine, and epinephrine over on the right. And if you can see those arrows in between the catecholamines, you'll notice between norepinephrine and epinephrine, you've got COMT there, and you've got dopamine's got the COMT as it converts to homovalinate, one of the organic acids that we can also monitor. So that's where COMT comes into play. What you don't see on this slide is that phenylalanine needs and tyrosine need MTHFR to convert to dopa in the catecholamines. The way it's written on this slide is BH4. Now BH4 stands for tetrahydrobiopterin. Tetrahydrobiopterin requires MTHFR function in order to be produced in the body. Thank you for that, Dr. Ferdinand. All right, so next slide shows us our biochemistry of serotonin and melatonin production. So on the top left, you got tryptophan and that big green lettering. Tryptophan becomes 5-HTP, which becomes serotonin, which becomes melatonin. So again, we need MTHFR production to help with the tetrahydrobiopterin in order to produce our serotonin. So it's really important in order for people to be happy, for people to be calm, and for people to sleep for our MTHFR to work. So we have a lot of kids not only have developmental and anxiety issues, but also have sleep issues. We'll move on to the next slide. Here's just a little graph on how tetrahydrobiopterin produces all of our neurotransmitters. So again, just a flow chart for that for those of you who love biochemistry. Next slide. Okay, and more of the same, how methylfolate regulates the tetrahydrobiopterin production, which again is essential for neurotransmitter production. Next slide. All right, here's this is the slide that has it all. And again, Dr. Ferdinand will go in more detail on this. If you look at folic acid up at the top of the slide, we get folic acid in our foods, we get it in our supplemented foods, we get it in our vitamins. Folic acid goes straight down this picture, down at the bottom, becomes methylfolate, 5-MTHF, okay? In order for that conversion to happen, if you look at 5-MTHF at the bottom of your screen, just above that is the enzyme MTHFR. Okay, the R is unfortunately on the other line, but MTHFR. That's where this enzyme helps. This enzyme converts folic acid into methylfolate, all right? And it's necessary for methylfolate to go reduce homocysteine to help with cardiovascular inflammation, as you see on this graph, but also all those neurotransmitter productions. Okay, next slide. All right, so again, at the end of the day, MTHFR is important because it produces the neurotransmitters. And if you genetically have MTHFR that is not functioning well, then the best treatment for it is to supplement with methylfolate, because that's what the MTHFR gene does. It produces methylfolate. So you can just take that as a vitamin and stuff starts to work. So here's my patient after 2 months of methylfolate. As you can see, his 5-HIAA levels have gone from a 3 to a 12, fantastic. And his catecholamine levels down below have gone from absent to low normal range. So that's great that we've increased everything in the lab work. More importantly, obviously, is how he is clinically. So the next slide kind of reviews him clinically. Now this slide again, sorry, interruption of this slide. As we know, the protein and the vitamins equal our brain chemicals and our neurotransmitters. Next slide. So our patient is doing well on the 2.5 milligrams of methylfolate. He's more social. He's happier. He's less anxious. He has more friends at school. He's more comfortable with himself. And why? Why are these symptoms better? Because the physiology is better. The serotonin is higher. The catecholamines are higher. All those things that make us feel good are increased in our brain, and therefore our symptoms are better. And where did this all come from? This all came from this inherited genetic mutation. And with the right treatment at the right part of physiology helps people feel better. And that's where methylfolate supplementation does so well for so many of our kids, not just with their mood, not just with their anxiety, not just with their social development, but also with their learning. Okay, you need dopamine to learn. And a lot of our kids with low dopamine, kind of coming off the clinical case here, kids with low dopamine don't get rewarded. So a lot of the kids have problems because they're not bribable, and they don't do well with positive reinforcement. And that's such a great learning tool as parents and teachers for us to help kids, is with positive reinforcement. You're like, oh, you peed in the potty. Great, good for you. Sorry, I've got a 3-year-old with potty training, that's why I say that. You peed in the potty. You got an A on your exam. You did well. You cleaned up your toys. You cleaned up your room. And I'm rewarding you with my positive reinforcement. And a lot of kids thrive on that. But if you have low dopamine, you don't. I call these kids unbribable, okay? Because without the dopamine, I don't feel good when you compliment me, okay? And if I don't feel good when you compliment me, then your positive reinforcement is worthless, okay? And as I tell a lot of parents in my office, you could give your kids $1,000 to clean their room, they're not going to do it because they don't care. They don't get that good feeling, okay? So it's these neurotransmitters are really involved in so much of our life on a day-to-day basis. So the next slide. Okay. Here's some interesting things to keep in note when you are using methylfolate supplementation. Just because we change your brain chemistry doesn't all of a sudden change your life, because it will change your feelings, okay? It will make you happier. It will take away fear and anxiety, but the memory of how you were still remains, okay? And the memory of post-traumatic situations are still there. And a lot of fear and anxiety and PTSD comes because we expect something traumatic to happen in a similar situation. So anytime that we go near that situation, whether it be kids at school or in the dark or what have you, we're still going to be a little anxious about it, even if my brain chemistry is better. So that just takes time to change. And it takes repetition of feeling better in the same situation for us to relearn that. And that's all about behavioral habits and emotional habits, okay? If I always feel sad here, I'm expecting to feel sad even if my serotonin's better. It's going to take some time for my serotonin to be happier and me to be happier in that situation for me to relearn things. So it's not instantaneous. There is some time for everybody to get used to feeling better. And as I tell my parents, you know, if we're working on your kids feeling happier, you're going to have to give them that emotional space to be happier. Because if you always expect them to act in a certain way, whether it's sad or angry or a temper tantrum, if you keep expecting that, they may mold to that. So give them the opportunity to be better and to be happier. Next slide. Okay, great. Dr. Ferdinand's going to go more into the details of this, but obviously MTHFR mutations are a combination of C677T homozygous normal or abnormal or heterozygous and A1298 homozygous normal or abnormal or heterozygous. And of course, there are other SNPs in MTHFR. My thought process is if you've got a mutation, treat it. I mean, the goal of lab work is to pick a treatment that's going to work. So let's try that treatment and see what happens. Next slide. All right, and obviously the MTHFR mutation can come from mother and father. Next slide. All right, this is a really cool slide, and I think Dr. Ferdinand has this as well. This is the percentage of mutations in different populations. So as you can see, that blue is homozygous normal in the 677. The red is heterozygous, and the yellow is homozygous abnormal. So let's take, for instance, U.S. Caucasians. You know, we've got 40% heterozygous, 10% homozygous, according to this study. That's 50% of people who are at risk for depression and heart disease. And that's, you know, those are two of the top 5 conditions that we deal with in the health profession. So MTHFR really just, you know, MTHFR mutations and treating them can help so many people. You can also see that people with Mexican ancestry have a really high level of homozygous potential for the 677, and that's, you know, that's a problem when we look at heart disease as well as cancer in a lot of people with Mexican ancestry. All right, next slide. All right, how do we dose? We dose based on effect. Okay, this is not weight, this is not size, this is not you name it. It's based on how the patient reacts. So doses can go from anywhere from 1 milligram to 15 milligrams in my office. That patient we had with the case study was 2.5 milligrams. We often give it with methyl B12 because those work together like peanut butter and jelly. Dietary sources are really minimal, okay, because most of the foods we have folic acid, or we have fortified foods with folic acid or folate in them, okay? Fermented foods are possibly a source of methylfolate, and more research needs to go into this because bacteria also have the MTHFR gene and enzyme. So really the question out there is, can a bacteria, when fermenting a food, convert folic acid and folate into methylfolate for us? So kind of an interesting thing. Everybody eat more sauerkraut. Next slide. All right, now let's get into the COMT gene. Excuse me. If you're taking methylfolate and you feel worse, you feel more angry, you feel more aggressive, you feel all of this extra stress and anxiety, these are the side effects that occur when we have COMT mutations, okay? Because COMT is responsible for the metabolism and the removal of our catecholamines, okay? So methylfolate supplementation will help increase your serotonin and increase your dopamine and increase your adrenaline. And this is great, especially for people with anxiety, because we need these things to feel happier. But what if you're increasing these levels of things, but you can't get rid of them, okay? And I always go back to that I Love Lucy episode where she's in the chocolate factory, and those chocolates keep coming faster and faster and faster and faster. She can't handle it. And that's the COMT gene. She can't handle all these chocolates pouring down through that factory, and that's what happens to adrenaline and people with COMT mutations. They can't handle their adrenaline. They start to get angry. They start to get aggressive. So how we can help with that is a couple of things. First is a combination of B6 and magnesium. And Metabolic Maintenance has a great product called InGear, which is powdered B6 and magnesium that really helps reduce this hyperactivity. And it's interesting that that formula was actually based upon a research study that B6 and magnesium helps hyperactivity in ADHD kids, which it does because it takes away that hyperactivity that's caused by excess adrenaline. We can also consider some molybdenum supplementation for people who also have CBS gene mutations. Again, we're kind of getting off the MTHFR and COMT stuff, but molybdenum is important as well. Next slide. I'm just happy I got through that slide and said molybdenum correctly. So the COMT mutation is responsible for the metabolism, again, specifically the adrenaline. If you're building up the adrenaline and you're not removing it, then you're going to become more aggressive, more angry, more anxious, and these are the people who get worse on methylfolate supplementations, okay? So ironically, if both your MTHFR and COMT are affected, you're usually okay because you're producing less and you're removing less. But if only one of them is mutated, that's when you start to get symptomatic, okay? So you can have both working half and you're okay, or you have one of them not working and you're not okay. Next slide. And this is where testing just helps us. You know, testing really helps. Oh, good. Here's the slide on B6 and magnesium. Here's that InGear product. You know, it's really great. We use this in a lot of patients to help calm down that hyperactivity. And of course, a lot of research on autism. I mean, B6 magnesium research for autism has been going on since the 60s. So always a great thing to use. Next slide. Here's a little bit on monoamine oxidase. And again, this isn't one of the genes that we're going to focus a lot on, but it's something else to consider looking at if your MTHFR and COM treatment don't get you where you want. Next slide. So how else can we support? We can support with amino acids, okay? 5-HTP is great because it upregulates our serotonin. It also downregulates our catecholamines because we've got absorption competitiveness across the blood-brain barrier. So if you flood the brain with more 5-HTP, it'll absorb that more and absorb phenylalanine and tyrosine less. Therefore, we can downregulate catecholamine absorption just by giving 5-HTP. If you don't want to do that, you can give 5-HTP and phenylalanine concurrently, but you do have to be wary of hyperactivity worsening with phenylalanine supplementation, so we don't do it a lot. Also, GABA is one of our most effective amino acids. Has nothing to do with MTHFR or COMT, but really helps with anxiety and OCD by helping people calm down. Theanine is also good because it acts as a glutamate antagonist, and glutamate obviously is a neuroexcitatory chemical that is very problematic in these kids with developmental delays. Next slide. All right, so why would I use methylfolate versus Deplin? First off, methylfolate comes in a wide variety of doses, anywhere from 2.5 to 5 to 10 to 15. You can give it with different cofactors such as methyl B12 and P5P. And this is where Methyl Pro is wonderful because it gives you all these different dosing options. No prescriptions necessary. It's licensed and sold as a dietary supplement. Deplin, on the other hand, only given in 2 doses, 7.5 and 15, does not come with the cofactors that are necessary to help encourage neurotransmitter production. It's extremely costly, rarely covered by insurance. And one of the concerns that we've had with prior patients is all the inactive ingredients. We've had other people take Deplin and have side effects because they were allergic to the inactive ingredients. So be careful that if you have a bad reaction to Deplin, you may still be able to use methylfolate. Next slide. All right. Here's an interesting slide that, again, doesn't really, well, it does, sorry. This shows how alcohol and ethanol can inhibit all of your neurotransmitter and MTHFR biochemistry. Now, I hope nobody's given their kids alcohol. However, if a child has a yeast infection in their intestines where a byproduct of that yeast is alcohol, the child could be decreasing their methylfolate physiology just by having that yeast. So any of you who homebrew like myself, how do you turn beer or wine into alcohol? You feed it yeast. You put that yeast inside the beer or the wine you're making, it eats the sugar, converts it into alcohol. So anybody who eats sugar and gets really giddy and maybe a little drunk, it's because that person with that unique yeast infection is producing alcohol. And that not only will make you giddy and a little drunk, will also mess up with your neurotransmitters. Next slide. Here's some of the research. Research is hit or miss, but one thing that's most important is treat your patient as an individual. Test their genes. Look for their MTHFR. Look for their COMT, and start to treat and see if the treatment works. Next slide. Another one on autism, a lot more MTHFR mutations known in autism. Depending on the research study, it'll tell you that there is an increase. In my office, 90% of our kids on the spectrum have MTHFR mutations. I mean, it's clear correlation. Next slide. And therefore, the majority of our kids get methylfolate treatment. Dr. Ferdinand, is this where I pass the baton?
Yes, I think you've done a phenomenal job on explaining some of the background of MTHFR and COMT in these patients. And if you don't mind, I'll take it from here.
Great, thank you.
So what we've recognized here at Kashi Labs, kind of to mirror what Dr. Skowron has said, is that we do see a higher occurrence of MTHFR polymorphisms in our tested patients. What we see in the patients that doctors have selected to have testing run through Kashi Labs is that 86% of these individuals have at least one MTHFR polymorphism in either the 677 or the 1298 alleles. This is a large and significant increase over what we see in the general population. If you look at the graph that Dr. Skowron has shared with us earlier in the presentation, we see roughly for a TT homozygous in the Mexican community, which is going to be your highest presentation here, we see 40%. So this, if you take a snapshot of individuals that are showing symptomatology, individuals that are selected by their providers to be tested, we're seeing a very high prevalence of these treatable polymorphisms. So when you're looking at the testing, these are just some of the possible testing outcomes that you may have. With the MTHFR, as mentioned, we're testing the 677 and the 1298. With that, you can have either a homozygous or a heterozygous presentation in either of the individual genes or a compound heterozygous state in both genes, meaning there's at least one mutation at both locations in the gene. For COMT, the allele that we're testing is commonly referred to as the Val158 MET allele. There's three possible situations that can arise when patients are tested in this situation. They may come up as a Val-Val homozygous, meaning they have two valine amino acids at that location. May come up as a MET-MET homozygous, having two methionine amino acids at that location, or they may come up as a Val-MET heterozygous. So we'll get into that in greater detail when we talk about the COMT test. So just very briefly, for those of you who have been with us in our previous webinars, you'll have a good understanding of what our test kit consists of, but those of you that may be new to us, it's just a brief little overview. All of our test kits are delivered via buccal swab. Very, very simple to collect in all patients of all ages, including children. In fact, we have patients and their parents thank us commonly for the ease of collection through the buccal swab. It's very easy to collect in office or at home, or if you have a virtual or a distance-based practice, it's something that can easily be drop shipped to your patients. All of our test kits come with very simple to understand collection instructions to ensure that we get the best quality sample available. When we receive your sample, we of course process it and then issue you the report. This is a representation of what our MTHFR sample report will look like. As you can see, this individual came up very similar to Dr. Scowron's patient in our case study with one mutation in the 677 allele. This gives this patient roughly 66% of the expected enzyme activity. Therefore, this patient has a 1/3 reduction in the ability to convert dietary folate into active folate that the body needs to properly generate our neurotransmitters and function ideally. As Dr. Scowron alluded to, there's many ways that we can support these individuals. The very first thing that these individuals are going to need, of course, is going to be active folate. And like Dr. Scowron said, this is going to be dependent upon symptom picture, it's going to be dependent upon age, it's going to be dependent upon body weight, it's going to be dependent upon how they are reacting to the supplement, but it can also be guided somewhat by what the polymorphisms are. We'll get to that in just a minute. But we can't just stop with methylfolate. We need to ensure that we're supporting with other B cofactors. Methylcobalamin B12 is very important to ensure that the folate is processing forward in the 1-carbon pathway. We also need a full active B complex that very importantly needs B6 and B2 riboflavin. Very important, as these are key cofactors to proper functioning of the enzyme. Now, beginning dosing with these patients, there's a lot of factors to take in, but if you have an understanding of what their genotype is, that may give you a good understanding of where you can begin dosing. If we have an individual with the 677T homozygous situation, that is the individual that is going to be the most severely affected by these changes. As you can see, that individual has roughly 25% of the expected enzyme activity. So based upon their symptom picture and the knowledge of their genotype, we may be able to start a little bit higher on the spectrum of the 2.5 milligrams to the 15 milligrams dosing to get them to a more stable place sooner. And that goes down as through the different genotypes. As we see, the compound heterozygous is our next most affected with roughly 48% expected enzyme activity. 1298cc, the homozygous in that allele location, is our next most affected with 61%, very close to the 677CT in our case study with 66%. So these two may want to start something more intermediate to low to give them better sense of control. Now, when we get into individuals that have only one mutation, the 1298, we don't see as severe of a reduction in enzyme activity, so starting them lower is going to safeguard against those potential side effects more readily. And of course, for individuals that have no polymorphisms but are still showing some symptoms, we may still want to start and support them with a very low dose just to ensure that they're getting proper active folate in ratio to folic acid that is so prevalent in our dietary sources to ensure that they get better symptom relief. Now, to come back to the COMT polymorphisms, one thing that's very important to understand about them is that these two possible alleles are co-dominant. Therefore, each allele exerts the equal influence on the outcome of the enzyme as the other. So very often when we're talking about COMT, people just think about the MET allele because that is what is considered our variant. That's the one that is going to show a reduction in COMT activity, and therefore we're not able to degrade the neurotransmitters as effectively. However, the VAL-VAL allele is also an issue for some patients, as this one is able to degrade the neurotransmitters more effectively, and in some cases, if the patient is not properly balanced, may not have enough neurotransmitters to have proper symptom relief. So testing will give you a better understanding of where your patient is and how to address them most appropriately to get them relief. Now, what we experience because of this codominance in the VAL-MET heterozygosity is a theoretical best outcome. These individuals theoretically have balanced neurotransmitters. We have the high activity enzyme and we have the low activity enzyme that together give a bit of a sweet spot as to where the neurotransmitters are best produced. Of course, that doesn't mean your patient isn't symptomatic, and we'll give hints as to how to address that as well. So our COMT sample report very clearly shows which type of patient your patient is. This particular individual with the AA genotype will represent the MET amino acids at the allele. This individual represents the low activity and therefore has a higher amount of neurotransmitters available. So we want to be able to support them to balance out that neurotransmitter excess. What we can do with that is we could support magnesium, as it is a necessary cofactor for proper COMT function and proper substrate binding, but again our active B complex, because we need proper methylfolate, we need proper B12, we need proper B2 and B6 to ensure that the dopamine metabolism is occurring appropriately. Other things that we may want to utilize to help your patient, depending upon their symptom picture, is things to support serotonin production to be able to balance out those excessive catecholamines. So 5-HTP or L-tryptophan may be of some benefit to these patients. And of course, SAMe. SAMe is a wonderful cofactor that provides an exogenous source of the S-adenosylmethionine that is needed in the COMT function, but also in proper MTHFR function. So if we can supplement with that, not only do we get a calming effect for our patients, but we also get better effect at the enzyme, both COMT and MTHFR. With these patients, we definitely want to avoid excessive L-tyrosine and L-dopa sources. This may predispose the pathway to overproduce neurotransmitters, and in these individuals that already have a higher level of neurotransmitters, it may set them off to be even more unbalanced. To look at the other side, this sample report looks at an individual that comes up with the GG genotype. So this individual has the Val-Val polymorphism. These individuals are going to represent the higher activity COMT, the one that is able to degrade and move the catecholamines more effectively. And again, based upon nutrition, these individuals may be catecholamine and dopamine deficient and have more of a blunted affect. So this is still something that through knowledge of their genotype we can address effectively. What we want to do with a Val-Val support is in some ways opposite to what we want to do with the MET-MET support. We still need the active B complex because all of the neurotransmitters are necessary cofactors for neurotransmitter production this time. But other things that we can utilize is going to be vitamin C to support the tyrosine hydroxylase enzyme that is one of the first steps in dopamine production. But it also exudes a mild inhibitory capacity on COMT. And the same thing can be said for vitamin D. Vitamin D upregulates tyrosine hydroxylase and is also a mild COMT inhibitor. One thing we can also integrate, whereas we were avoiding it with the MET-MET individuals, is L-tyrosine and L-dopa if these individuals are showing that more blunted affect to give them proper precursors for neurotransmitter production. And green tea with a mild suppressive effect on COMT can be used to improve neurotransmitter levels and also is just a neuroprotective. So, with the individuals that have one of each of the amino acids, the Val-MET heterozygotes, theoretically these individuals should have balanced neurotransmitters. But if you've tested them, they have some symptomatology that led you to think that there was an imbalance. So what do we do there? We look for something that may be pushing the pathway in one way or the other. So if your patient is easily stressed or excitable, their MTHFR dosing may need adjusting. They may be having a high amount of COMT inhibitor intake through excessive amounts of vitamin D, vitamin C, green tea, or xenobiotics. A lot of things that we encounter in our environment can inhibit COMT function. So doing a proper environmental analysis and possible look at detoxification pathways may be a good appropriate approach with these individuals. For those individuals with less focus and a more blunted affect, more looking like our val-val situation, we may want to adjust our MTHFR dosing again, either up or down, and support with aminos and good nutrition to ensure proper neurotransmitter production. So with that, Dr. Scouron, I'd like to hand it back to you so that you can talk about some of the products used to support these patients.
Great. So first off, I've had the pleasure to work with metabolic maintenance for a long time, 2006 to 2013. Worked hand in hand with metabolic maintenance. They're an amazing company that makes amazing products, and they're the #1 brand that we use in our office. So let me just give you a highlight of some of the metabolic maintenance products that and methylpro products that are out there. They've got 5-MTHF in 2.55 10 milligram doses. They have methylfolate in their B complexes, which also include methyl B12. The methylpro also comes in the 2.55 and 10, but also in the 15 milligram dose. It's also available to the public with methylpro, where metabolic maintenance is available to health professionals. They've got B complexes with 5, 10, and 15 milligrams, as well as kind of cofactors with the methyl B12, the P5P, and the magnesium in the 10, 15 milligram doses, which is great because now you've got MTHFR and COMT treatments in one pill. Okay, so that's really where this stuff is such a wonderful product for your patients. Next slide. These are two formulas that I put together to help kids on the autism spectrum. The one on the left is a metabolic maintenance product called Spectrum Awakening. On the right is my brand of product under the brand Spectrum Awakening with the name Power and Focus. So a little bit confusing on the terminology, but the one on the right is available to the public, the one on the left is available to health professionals. Very similar products where we're focusing a lot on high-dose amino acids, theanine, as well as our activated B vitamins, the methyl B12, the methylfolate, the P5P. Excuse me. The one on the left has got a couple extra ingredients. The one on the right doesn't. Vitamin E and biotin and selenium. So a few minor differences, but they're both great because they're, again, both developed for kids in my office, for kids on the spectrum. They're both powders, so you can mix them into any kind of food, any kind of drink. Get these methyl vitamins and the magnesium and the amino acids all in one. And I really put together these formulas because parents felt great that these supplements were working for their kids, but they felt like a pharmacist. They're like, oh, I'm opening up 10 pills a day to try to get this in them. Now it's a powder. Now it's all in one. So two wonderful formulas to try. Next slide. Great. So now I've got the pleasure to hand it over to Ed Fitzgerald. He has been the founder and CEO and owner of Metabolic Maintenance and methylpro for, geez, we're going on 30 years, I think, Ed. And again, it's been great to be working with him side by side for many, many years. So let me turn it over to Ed.
Thank you, Jared. And thank you, Dr. Ferdinand. Quite extensive explanation of the lab results and with you, Jared, how to apply them with your patients. As Jared mentioned, we started, my name's Ed Fitzgerald. I started Metabolic 31 years ago, and methylpro is going on 4th year. And I just wanted to take a second and draw a distinction between the two. We sell, Metabolic sells to about 18,000 and counting practitioners in this country. And methylpro is designed to go directly to the patients of psychiatrists. And we discovered this need when we went to a psychiatry show in San Diego, where 2,000 psychiatrists attended, and we at that point just had the metabolic products, and we were covered up. Our table was covered up by doctors 3 and 4 deep, wanting to know more about us because they have patients on Deplin that it was more expensive than a lot of their patients could afford, and so there was a barrier to entry. So what we discovered was it would be a whole lot easier for us to sell it directly to their patients rather than go through a pharmacy and have it sold only through a pharmacy, as Deplin is. And the major distinction between Methylpro and Deplin is Methylpro is a nutritional supplement, can be sold directly to the public, and Deplin is a medical food and can only be sold either to a doctor who can dispense, but more typically through a pharmacy. So Methylpro started with just a 2.5, a 5, and a 15 milligram product, and 15 is still our most popular. But as Dr. Ferdinand was explaining, and Dr. Skowron as well, you need support for some of these single doses with other nutrients, primarily B complex. We have some with, obviously, that need some magnesium as well. And that's when we ended up developing. We started with 3 products, now we have 10 that address all the way from the lower dose, 2.5, 5, 10, 15. The lower dose also has some B complex with cofactors. And we came upon this in listening to doctors, listening to psychiatrists. And the reason that we decided to go directly to the psychiatrist patients is psychiatrists just don't dispense. And by us going directly to their patients, we were able to save quite a bit of money for the patients and the psychiatrists if they wanted to keep those and dispense them to their patients. We recently moved. Oh, we can change the slide here somewhere. There we go. Let's try it again. There we go. Yeah. Okay. There we go. We recently moved into our state-of-the-art facility in Sisters. We still have our other facility, which is doing absolutely custom. We call them one-off products. Doctors that want to order a product exactly for a certain patient is now our old facility. Our new facility, as you can see a slide there, is we're very proud of. And all of our products are excipient-free, meaning there's nothing other than active ingredients. And we're changing all of our Methylpro products and all of our metabolic methylfolate products to contain glycine in them because, as one of our psychiatrists pointed out, people with mood disorders typically will have a methylfolate deficiency, but also if they have mood disorders, they have sleep disorders, and glycine will aid in their sleep. Again, ours are excipient-free, vegetarian capsules, in glass bottles, and that wraps it for me, Dr. Ferdinand, Brian, and Jared. And thanks again for including me in the webinar.
All right, thanks guys. That was a wonderful presentation. We have a couple of questions from the audience I'd like to go ahead and share for you that have come through, and so we'll just get started. One of the questions was, what's the difference between quatrefolate or quatrafolic and other supplements?
Okay, I'll take that one. This is Ed. There are 2 companies that make methylfolate products in the country. There may be a Chinese company, but I'm unaware of that. The 2 primary companies are Merck, which makes the Deplin products, and Gnosis, which makes our products. And Gnosis is a biotech company in Milan, Italy. And Gnosis makes a quatrefolate, which is a glucosamine salt. And the other products they have another product which is called extrafolate, which is the calcium salt, and the Deplin product is also calcium salt. So the extrafolate and Deplin's product are both calcium salts, chemically identical. The other product, the quatrefolate, is shown to have a little more stability, so we like to use it in our combination products. The single products have fine stability as is. We find that with multiple ingredients, the quatrefolate really helps with stability.
Great, thanks, Ed. Next question is, I've heard that long-term care insurance is still able to discriminate and deny individuals for pre-existing conditions, including genetic risk factors. Dr. Ferdinand, is that a question for you maybe?
Sure. So I can touch upon the insurance aspect a little bit with genetic testing. So when it comes to insurance, there's only 3 categories that can, at this time, discriminate based upon genetic testing, and that's long-term care insurance, life insurance, and military insurance. However, for those individuals that are looking for just basic insurance, such as your day-to-day health care with your PCP, your naturopath, chiropractic, etc., there is government mandates put in effect that there can be no discrimination in exclusion from insurance coverage or change in premium status based on genetic testing. So at this time, yes, there is unfortunately some exclusion lines in the act about long-term and life insurance and military insurance, but everyday insurance is not to be affected.
Great. Yeah, I think the key point there would be educate yourself. Definitely. Thanks, Dr. Ferdinand. The next question is there a danger in using any of these treatments for Alzheimer's treatment? Dr. Skowron, maybe that's a question for you?
Yeah, sure. I think all of these would definitely be safe when it comes to working with people with memory issues. You know, and there's a couple different categories of memory issues. You know, when we look at patients with Alzheimer's diagnoses or dementia diagnoses, they are having problems making new memories and problems remembering old memories. So this would be a safe treatment to try. I would also try a disaccharide called trehalose. Trehalose is a supplement that is showing some good research with people with memory issues and dementia to help reverse that, because it's one of the few nutritional supplements that helps maintain healthy amyloid plaque removal as an mTOR independent agonist.
Great. Thanks so much, Dr. Skowron. Next question is, do we need to check both identical twins for SNPs? Dr. Skowron, I think you might have some insight on that.
Yeah, I do, and we've got a lot of identical twins here in the office on the autism spectrum. Every time I've tested them, they've came back with identical MTHFR and COMT mutations. So I think if you've tested one, you can presumably have the results of the other. However, random mutations do happen. I mean, that's Darwin, and that's how genetics occur. So it never hurts to test 2 people, but I think you're pretty safe to assume similar genetics in identical twins.
Great, thanks so much. Next question is for Ed Fitzgerald. Are the products available in the UK, and if so, how can they order them?
They are available in the UK. Initially they would need to call us, and I guess they could email us at www.mtfhr.com, and we'll get back to them and let them know what phone number to call us. Initially they would need to call us and set up their account, and from then on they could just enter their account via email on our website. But yes, they are. We sell quite a bit in Canada as well as the UK, and they are available in both places.
Sounds great. Thanks so much, Ed. All right, everybody, that wraps up our questions. I want to thank you all so much for joining us today. I hope you find the information valuable. If you have any questions about supplements, definitely reach out to the fine people at Mtfhr or Dr. Skowron, Spectrum Awakening. And if you have any questions on genetic testing or implementing it in your practice, we'd be happy to help you at Kashi Health. Thanks so much, and everybody have a great day.